Dr. Peled, thank you for joining me once again for a JawHacks podcast. I think the last time we spoke was 2 years ago, coming up on 2 years ago.
Yeah.
You're the surgeon who did two migraine nerve decompression surgeries for me. You, in pretty unorthodox treatment modality to surgically address headaches. Many of the audience members on my channel suffer from neck pain. To
hmm
their mind, that has to do with the anatomy of their jaws, potentially an airway issue that's causing bruxism at night, where they clench their facial muscles, which can then translate to neck tension.
Yeah.
Um, Also, airway issues can cause neck posture problems, which can also irritate neck muscles, which can then in turn irritate neck nerves. Could you explain, what you see when you open patients up and look at compressed nerves in their neck? What's going on with the anatomy of someone who suffers from occipital neuralgia?
Yeah, that's a great question, Ronnie. So first of all, thanks for having me back. It was a great conversation the first time. Looking forward to another great one this time. And I've heard a lot of your stuff. I really love it. I think you do a great job. So
Thank you.
in terms of what happens, I think there's a couple of things that you see. Number one, a lot of times you can see fascia, meaning the coverage of the muscles in all mammalian tissues, but also in some like avian tissues. For example, the fascia, the analogy I give to most people is if you've ever kind of bought a breast of chicken or turkey to cook at home at some point, and you have that sinew sometimes in between where like a little piece of tendon may have come out. It's very tough, thick, fibrous stuff, almost like those Tyvek like cloth envelopes. You could put a 50-pound brick in it and shake it, and the thing doesn't tear on like the paper bag. You see that fascia, which is the covering of all the muscles in our bodies, is very thickened. Now, sometimes that can be just how you were born. Sometimes it can be as a result of trauma. Sometimes it can be a result of certain types of activities. So, for example, I've treated a lot of athletes over the years, and some of them have done contact sports in which they've developed occipital neuralgia as a result of trauma. But a lot of them have non-contact sports, for example, weightlifters. But we're talking like national, international level competitive athletes putting up 400 or 500 pounds and cleans and jerks and things like that. And in order to support your tissues, your body tries to deposit more collagen to thicken those areas up to help support everything as you're really putting up these large stressor, in this case, weights. So you see that thickened fascia, and these nerves or these soft little wet noodles are trying to pass through these structures. And obviously they're not only just thick, but they become less pliable the thicker they get. And there's even a really nice paper out of the Massachusetts General Hospital demonstrating that in unilateral patients that they operated on, let's say you had right-sided greater occipital neuralgia, what they found was that the fascia on the right side of the neck was noticeably thicker than the fascia on the asymptomatic side. And the only reason they looked at the asymptomatic side is because you could kind of see it through that same incision. And so that's one type of thing. The other thing that I've seen a lot more in the last few years, and it's probably because I'm noticing it more, having seen hundreds and hundreds of cases, probably actually several thousand at this point. The anatomy of the nerves is not always consistent. And what I mean by that is, for example, I saw this just yesterday. The greater occipital nerve and the third occipital nerve are supposed to basically have almost parallel courses. And if you Google these or look at an anatomy textbook, the nerves never like actually interact with each other until they get to like the spinal cord, which is way beyond where we're at. However,
And just give us some context of where in the body you're talking about. Maybe the audience doesn't know what the
yeah,
occipital
so
nerves are.
if this was the back of my head, okay, and I was actually staring at the blinds, if this was the midline, okay, the greater occipital nerves kind of come out just a little off to the side of the midline, and they head cephalically, meaning toward the top of the head, and laterally, meaning toward the side, right? The third occipital nerves traditionally kind of come out just on the inside, on either side of the midline rather, and then typically head kind of straight up. And they don't go very far. They go to about here, whereas the greater occipital nerves can kind of go way over the top of the head, which is why sometimes people will describe this kind of radiating thing that goes all the way up here. Well, those two nerves are supposed to run in parallel paths, okay? But I can show you examples of, and we published this last December. There are certain, quote, anomalies, and they're probably less anomalous than we would think, where the third occipital nerve will actually have a branch that connects with the greater occipital nerve. And since you also have big pieces of muscle in between these two nerves, the problem becomes when you have a relatively big branch here and a relatively thick trunk here, and this tiny little twig, okay, which my thumb doesn't demonstrate well, but pretend my thumb was the size of a little string. And now that muscle moves in a certain way, that little string can get torn or stretched and then scarred. And because you have that type of anatomy, if you have an even seemingly innocuous, we'll say, injury, like you just get up one day too soon and you feel like a crick in your neck, that little muscle spasm can tear that nerve. And to the point I think you were making, and probably of greatest interest to your audience, would be it doesn't even necessarily have to be trauma. It can happen as a result of secondary issues with your airway or your orthognathic anatomy that will put more tension and pressure on these areas. And again, to cite some literature, there's a paper sometimes back, and I'd be happy to send it to you, so you could probably put it as a link to the notes on this podcast. But it showed that even as little as like 30 to 45 degrees of flexion in the neck put something like 60 pounds per square inch of pressure on the soft tissues in that area, including nerves. And given the fact that these structures are reasonably hardy, but they're not made out of rebar, even a lot of that kind of looking down to do all the texting at some point is going to damage those little nerve branches, and you end up with chronic nerve pain. And that was called text neck, which we still something I give my son a hard time about because he's now all about the phone all the time. So yeah,
aren't we all, right?
Yep.
So I think most of my audience, and probably most headache sufferers in general, and maybe even neurologists and people who treat headaches, are under the impression that headaches are primarily neurological,
Mm-hmm.
right? Like in the case of my audience, maybe they think that, oh, my brain is not getting sufficient oxygen because I have this sleep apnea issue, and this is wreaking havoc inside of my skull in the brain, and
Mm-hmm.
that this is somehow fogging things up in the brain and resulting in headaches. But the picture that you're painting is really more of a mechanical issue related to muscle dysfunction in resulting nerve impingement at the back of the neck. Can you speak a little bit about neurological headaches versus mechanical headaches?
Yeah, I mean, I think it's a great point. And so the way to think about this is, if you had a brain tumor growing on the side of your head and it was pressing on, let's say, a nerve here called the auriculotemporal nerve, and you had a lot of scalp pain too, the treatment for that would be, so that is a neurologic problem in this case because it's a brain tumor, which is the biggest collection of nerves in the body, but also because it's pressing on a nerve. You could make that analogy and extend it to the forearm. If you had a tumor growing in your forearm and it was pressing on a nerve, that is neurologic in the sense that the symptoms are in part related to compression or pressure on that nerve, and therefore you get the symptoms that kind of pathology would cause. But the underlying reason or problem is not the nerve. It's this mass pressing on the nerve. So where I'm getting at with a lot of the things that I do, and I say this to my patients all the time, we have this conventional wisdom and the mantras that people talk about when they talk about chronic headaches, like migraines, for example. It's all in the central nervous system. It's problems with blood flow to the neurons, certain chemicals irritating the neurons, all in the brain, blood vessels that are a little dilated when they should be constricted, because the neurons are misfiring. And the fact of the matter is that most of the time, and another main source of thought in terms of what causes these headaches are certain chemicals, right? So that's why you have drugs like the triptans that treat serotonin to help modulate the levels of that in the brain. Imavig, Emgality, Ajovy, Ubrelvy, Nurtec, all these newer generation of what are called CGRP, that's calcitonin gene-related peptides, really a mouthful, but it's this chemical that we have as, in a number of areas, but in the brain also, and it tries to modulate that. And it's thought to be basically a chemical problem. Okay. Now, if it was like diabetes, well, you might not be able to cure your diabetes if you take insulin, but you can certainly manage it that way. And the diabetes is the lack of insulin or your body's ability to produce insulin, so your blood sugar is high. So if you provide that insulin through a syringe, you then can lower that. But there are so many people right now. We have, I think, it's estimated around 39 to 40 million Americans who suffer from migraines and carry that diagnosis. And even if you take the rosiest outlooks with all the medication and conservative treatments that you have, like physical therapy, etc., all of which are very reasonable modalities to try. If you said, gosh, 70%, let's say 75% of patients do really well and their symptoms are totally manageable, they're very happy in that space, that still leaves close to 10 million Americans who would be running around going, yeah, I mean, despite all the drugs and all these other things and all the CAT scans and MRIs, I'm not finding good enough treatment for my headaches. And I'm still getting them every day. Sometimes it's 24/7 every day. And so I think that, and then in those situations, you then need to look for a mechanical cause. And I think that mechanical cause can come in the form of spastic muscle for any number of reasons, like small airway, bad posture, the muscles spasm because you're forcing them to contract in ways that people with, let's say, better posture don't have. But in your case, you're doing it because the airway that's the best way for the airway to function. Of course, if you don't have enough air, you don't work well. And that's, sort of a good example of what might be happening in some patients with sleep apnea, as they're often waking up multiple times at night, kind of jerking around. It could be because of a traction or stretch injury on a nerve that causes scarring either around the nerve so it doesn't glide as well, or within the nerve itself. It could be an enlarged blood vessel that, as we get older, and this is why oftentimes it's not as much of a problem in young children, for example, peak incidence of chronic migraines anywhere from 25 to 55 years of age. But as we get older, our lives are more stressful and blood pressure tends to go up a little bit. And so these blood vessels that are always running next to these nerves start pounding against the nerves even harder. What's come out very recently over the last couple of years is that when you think about blood vessels dilating or constricting, what causes that to happen? Well, it's usually nerves within the walls of the blood vessels. And there's a really interesting presentation that is apparently in publication yet, but I heard this data being presented a couple of years ago at our national meeting. And what it showed was that if you take the blood vessels of people who suffer from, let's say, greater occipital neuralgia, and you look at the blood vessels, it used to be thought very simplistically that these blood vessels were pounding against the nerves really hard. So it's a mechanical thing, very simply like that. But if you actually look at the blood vessels themselves and cut those out, which we do during surgery to try to remove them from the nerves, then you look at them under the microscope, you'll see that the architecture, specifically around the nerves in the blood vessel wall, is different and abnormal in people who have occipital neuralgia. And so sometimes as those blood vessels dilate, they're causing pain because the nerve fibers within the blood vessel, not within another nerve, are misfiring.
So are the nerves? So just the idea that blood vessels are themselves innervated is, I think, a little bit counterintuitive, because I think people imagine there's blood vessels and then there's nerves and they're separate structures. They don't think that blood vessels themselves what are they, little tiny, like hair-sized nerves that actually run the course of the entire blood vessel? Is that how blood vessels fire or function, is because the nerves
No.
give them signals?
So blood vessels function a number of different ways, right? There's like an inner lining where the blood flows through, and that lining is called the intima. It's very smooth. Then there's a layer within the blood vessel wall called the media, and think media muscle. That's where the muscle for the blood vessels runs. And what will cause the blood vessel to contract or to dilate is contraction or relaxation of the muscles in that tunica media layer. Now, how does your biceps flex or extend? It's your brain that sends a message or a signal down the musculocutaneous nerve that says, I'm going to do a bicep curl and I want to do this. And so your biceps flexes. And in the same way, there are nerves that run down these blood vessels that do the same thing to the muscles within the blood vessel wall. Now, you can't see these nerves because they truly are microscopic. So even in the operating room under high-powered loop magnification, we wear these big magnifying glasses on our operative shields, you can't see them. But what was interesting, and the way this came about, is that some people had what are called nummular headaches, and these are nummular just means coin-shaped, and these people who would come into the office, and it's pretty rare, but you could say, look, it's always right there. This pain is always right there. When you numb that, pain went away, and you would go in there, and sometimes you could find a little nerve branch, although this is not a common place to find a nerve branch. But most oftentimes, if you Doppler, so you listen to this area with what's called a Doppler ultrasound, but it basically makes a whooshing sound if you put it next to an artery or a vein. You would hear this very prominent pulsation. And when you open these people up, you would find kind of a dilated, very unusually large blood vessel. And you take that out. And so this guy had this idea. I was like, well, there's something about these blood vessels. I mean, the blood vessels themselves shouldn't cause pain, right? But he looked at them under the microscope and found that, the nerve fibers in there were not normal. And so, again, I think that, the upshot here is that there are lots of mechanical things that can irritate nerves. And in this case, it was the muscle fibers and the other microscopic cellular architecture of that layer that was abnormal, and it was pressing on the nerves. So there's lot of mechanical causes for nerve pain, which, yes, is neurologic in the sense that it's causing nerve pain, but the underlying problem is a musculoskeletal one. The underlying problem is a vascular one, meaning blood vessels. So.
And when you find abnormalities like that in blood vessels themselves and in the nerves of blood vessels, is that akin to a lesser occipital nerve or a greater occipital nerve having extra branches in a patient that you wouldn't find in a medical textbook? Or is that the result of abuse that occurs in microtrauma that occurs in a patient over decades that causes those nerves in those blood vessels to become abnormal?
Yeah. So that's the $1 million question. And I can speak to this with regard to the nerves themselves. So this patient that I saw yesterday had really unusual branching patterns and connections between the third and greater occipital nerves, which literally, you look at any textbook, most of the first 20 lectures I gave on this, these nerves were separate. They were next to each other. I would say, hey, look, this is just like the textbook. But you do more of these, you find these abnormal connections, and those connections are how the person developed once they were born and in utero. Okay. And in those cases, I think what happens is that trauma that for a person who didn't have that anomalous connection would not cause a problem, causes a problem in this person. And I'd be happy to, again, send you a copy of these pictures, and you can append them to the notes for this program. But there's a beautiful picture that I took one time where, the greater occipital nerve is one branch on this side, and two branches on this side. And the reason that's relevant is not because it's one versus two that eventually meets at a V, but because between those two branches, before you decompress them, you have this muscle, which is also here and also here. And the point is, if this branch is smaller and this muscle is really squeezing this one, this branch, which is hardier, might not move. Just like if you look outside your window and there's a tree there, if a 50-mile-an-hour gust comes by and you look at the trunk of the tree, it probably didn't even move. But if you look at one of those like little branches where there's a little leaf and there's a little twig there, that thing could snap right off. So those people are predisposed. Now, with regard to the nerves and the blood vessels, is that a function of trauma, overuse, high blood pressure? The answer to that is I'm not sure. I think we will learn that with more time, and I think that there's lots of ways to study that in the lab, etc.
Yeah. To what degree do you think divergent nerve anatomy contributes to why some patients get these headaches and some patients don't? For example, in my case, I'm kind of fixated and obsessed on this with this idea of my jaws being too small and causing my neck posture to be a certain way, and maybe causing certain muscles connected to my tongue to be overused as they attempt to hold my tongue inside a mouth that's too small, when if my tongue could just relax, it might flop a centimeter farther forward. And that, the muscles that are contracting my tongue inside of my mouth are somehow connected to muscles that are around my in my case, it's my lesser occipital nerves that I think are really problematic. And then people say, well, if your theory is correct that your small mouth is causing your headaches, why doesn't everyone with a small mouth get headaches like you? And the only explanation that I can come up with for that is the discovery you made when operating on me, which is that I have all of these extra branches coming off of my lesser occipital nerves, right? And which you removed many of them, and I got relief from that. But the reason maybe that I continue to get headaches, much less frequent, much less intense, much shorter duration when I do get them, but still get them, is that maybe there's still bizarre branches that are in there. So this divergent anatomy premise is fundamental to my understanding of my own headaches. What have you seen in the hundreds or thousands of patients that you've operated on? How common is it for people to have these divergent branches in nerve anatomy?
Great question. So, again, happy to share with you this paper because it's an open access journal, so anybody can read it anytime. I'll put the link in. You can read the whole paper. But the answer, as a lot of my Israeli colleagues would probably say, it's depend, right? So there are certain anomalies. So what I say to my patients now pretty regularly is there's no such thing as normal or abnormal peripheral nerve anatomy. If you think about the heart, for example, the reason we do this to say Pledge of Allegiance is because the heart is always in the left side of the chest. Now, that's not 100% true in every single person that's ever been born. There's a condition called dextrocardia in which the heart is in the right side of the chest. Those things are discovered usually in utero and sometimes at birth. And you have heart surgery and you fix that. But, that's like 1 in a million. Okay. It's a very rare thing. When it comes to nerve anatomy, there's no such thing as normal. There's only the most common variation. So there are certain variations that are pretty common. So, for example, a bifid greater occipital nerve probably occurs. I'd have to look at the paper to quote you the exact numbers, but in something like 25% of patients. I see it reasonably frequently. It's not everybody. It's not a majority, but it's not like I've never seen it before. But then there are people who have bifid supratrochlear nerves. And I'm not talking about one that goes up here and then branches. All nerves do that, but I'm talking there's like 2 nerves coming right out of here. There is a nerve like the supraorbital nerve that comes out more laterally, and it typically kind of goes this way. And I've seen it where there's like 5 or 6 different branches right off the bat, whereas it's not really supposed to branch until it gets north of all these muscles here that we frown with. So I think that this divergent anatomy probably accounts for 35% to 40% of overall a lot of nerve problems. And I think it's one of those things that people need to be aware of, in the sense that, so many nerve problems are really not perceived as nerve problems. And I'll give you another analogy, and this is also very much a mechanical thing. You strain to lift something heavy at work, you feel like a little pop in the groin. You then have groin pain. You go, oh, shoot, I think I have a hernia. You go see the doctor, they do a CAT scan, you have a hernia, they fix the hernia. And one of the things they do to fix the hernia is they put in a mesh. There's like a hole in your abdominal wall where a little piece of tissue came through, and that's what's causing the pain. So they take that stuff out, put a mesh, basically plug it out. Now there's no hole anymore. Post-operatively, you come to see me and you say, I'm still having pain. I don't understand it. It's a little different pain. It's kind of sharper. It's not as dull and achy. But yeah, no, it's still pain there. And so you do another CAT scan. You don't see a hernia. You do a physical examination. You don't see a hernia. So when I was a trainee in 1997, okay, you must be rejecting the mesh. And so we would do another operation. We take the first mesh out, put another mesh in. Post-operatively, still having pain. Then you get shipped off to anesthesia pain management, and you end up on chronic opiates and medications of various kinds. And, that's not the only reason, certainly, but a reason why we have an opiate crisis in this country. And this is what I was taught to think about when I saw these patients. Right now, when I see these patients, I just examine looking to press over certain areas. And if I find a little area where I press and the patient goes, ow, and I put a little bit of local anesthetic to numb a nerve, because that's the only thing the local anesthetic is going to do. And all of a sudden the pain goes away and they're jumping up and down. They go, this is amazing. The reality is the problem is the ilioinguinal nerve that got scarred or entrapped within that mesh. And I'm not saying that anybody has done anything wrong, or this is not how you manage hernias. Certainly, I'm not a general surgeon, and it's a very appropriate thing to do. But you have to pay attention to these nerves, because they're not always where you think they're going to be. And if you don't look for them, you'll never see them. My wife and I invented an operation where we can either preserve or restore sensation in women having mastectomies, because most mastectomy patients, thankfully, do well oncologically. Now we've got great treatments for the actual cancer, thankfully, and that's probably most important. We have many new, less invasive, meaning above the muscle, the pectoralis muscle techniques for reconstruction. And so aesthetically, women look terrific. But they used to be basically numb from armpit to armpit. And why is that? Because the sensory nerves to the central chest wall skin, including the nipple areola, are routinely cut during these mastectomies. And the question is, well, why does that have to be the case? We used to take out all the areola. We used to take out all the skin. We used to take out the pectoralis major and minor muscles. But it's not skin cancer. It's not areolar cancer. It's not muscle cancer. And it's definitely not nerve cancer. It's breast cancer. So what we need to take out is the breast tissue. And if you can identify the nerves and leave them, which happens about 25% of the time, people do really well once those nerves wake up. And if you have to cut part of the nerve out because you have to remove the cancer and the nerve is stuck to the cancer or is going through the breast tissue and you can't easily separate it from the breast tissue and you worry that you're going to leave breast tissue behind, which we wouldn't do, you have to take part of that nerve out, but then you reconstruct it. And now at some point when the nerve regeneration occurs, you can feel more and more and more. So
so tell me more about what the unique innovation that you and your wife Anne did in that surgery. I missed what was uniquely created by you guys as an innovation.
Yeah, so basically the idea is that you always had to be numb. That was just collateral damage when you do a mastectomy. And years ago, when you did flap reconstruction, so if I'm going to take, let's say, tissue from your abdomen, a little fat and some skin, and put that up here to reconstruct the breast mound, some people thought to take nerves that were also being cut at the abdomen, because there's nerves going to that abdominal wall skin, and try to hook it up to nerves in the chest wall. And that met with some success early on. And part of the reason for that is we now have better equipment, for lack of a better way to say it, meaning allografts, cadaveric nerve graft matrices that are really good at promoting nerve growth through their substance, as opposed to just a hollow tube where we thought we could just guide the neurons to grow. It turns out neurons, they want to grow through an actual nerve matrix. They don't want to just go through like the Lincoln Tunnel. So now having those, the results with that flap reconstruction of the breast is better, and women had better sensation. But what we also realized is that the skin covering a lot of those flaps, because most of those flaps are buried, meaning they're under the skin, and you can leave the areola, you can leave most of the skin when you do a mastectomy. So we just need to put in the soft tissue. Those patients were still saying, my soft tissue, I still feel numb when I touch the skin. And so the other thing is that 80% of the reconstruction done in this country is with implants. And so some women are not candidates for flap reconstruction. Some women don't want to have flap reconstruction. So much bigger operations, very safe, done well. But it's, often a multiple day hospital stay, and the recovery is a lot longer. It's a lot easier to place an implant. And the question was, well, if you cut out all the tissue, how can you reconstruct any sensation to the skin? And the reality is, I saw so many patients in my practice early on who had what's called post-mastectomy pain syndrome. Because, of course, when you cut a sensory nerve, sometimes numbness isn't the only thing you get. When that nerve grows back, if it's stuck in scar, it can cause a neuroma, which is a very painful structure. So I would see these women and I would find these neuromas of these intercostal nerves, meaning the nerves between the ribs, that were causing all this pain, and you could manage those in those cases. And then we realized, well, wait a minute, if we're doing that and we can do that, why don't we look for these nerves as we are doing the mastectomy? And if we can just isolate the nerves themselves and we can get enough length on them, can't we use these allografts to connect them to the underside of the nipple and areola that we're also saving, and ultimately bring sensation back? And so that's the innovation that we did. And so, when we first started doing this, it's almost 7 years ago now, the average length of nerve that I could save just outside the rib was about 2 to 3 centimeters. Now it's closer to 7 to 8 centimeters, which now means that, we used to have to use grafts that were this long. Now those grafts are shorter and shorter and shorter, which means the recovery and regeneration time is less, which means less time that you're numb. The more time you're numb, the longer the atrophy of that map in your brain to, let's say, the left nipple goes away and then has to be relearned. So if it doesn't atrophy, so to speak, that much, it comes back more quickly for a number of reasons. And so we've done that. We've published a couple of papers now. There's a number in the works, and other people have started to do it at Cleveland Clinic, and now at University of Pittsburgh and Cornell, and the Massachusetts General Hospital, which is the Harvard flagship hospital. So it's
that's remarkable. I feel like all the time I'm hearing about women getting breast cancer, and it seems to be a really big problem that's growing in our world. And the fact that there's now a way of dealing with that doesn't strip you of this other sort of essential aspect of life, which is your ability to feel your own chest is great. So where do you put that innovation in your sort of trophy case next to your treatment of headaches? Do you think that's your greatest achievement so far?
I mean, I think they're all, I try not to rank them. I mean, they're all amazing and wonderful. This one came out of my wife's own breast cancer diagnosis, and she's been very vocal about this. When she was sitting down thinking about what she would have done, she was diagnosed at 37. The choices were mastectomy, and then you'd be done with treatment and you don't need any more surveillance or anything like that. No other adjuvant treatment, but you'd never feel anything again, like your kids or grandkids hugging you. You do a push up or run and your arms are moving, you don't feel that move. Or you could have a lumpectomy, but then you have several weeks of radiation therapy with all the problems that can cause. You have to be screened. So because you still have a lot of your breast tissue, every 6 months, you're alternating MRI and mammogram, and then biting your fingernails off for a week going, God, I hope they don't find something this time. Again, You have 5 to 10 years of tamoxifen as hormone therapy, and that's for early stage cancer. You know, you may have chemotherapy and everything else if it's more advanced. And so those were pretty lousy choices. And the question was, as we were sitting around dinner one night, going like, well, why does that have to be the case? If I took a tumor out of your hand and it was impacting one of the major nerves, let's say the median nerve, of course we would try to reconstruct that. And of course that's what we did in prostatectomies way back in the late 80s, early 90s. We've been treating prostate cancer for a long time, but a lot of times men were, I think it was over 50% of men were impotent post prostatectomy. And at the time it was, well, how do we fix that? That's just not an acceptable outcome here, even if the cancer's gone. And so, at the time it was Patrick Walsh, who was a urologist at Johns Hopkins, realized, look, if we can basically control the blood vessels at the beginning of the operation, then we can cut through everything and it wasn't a bloody mess. And then we can all of a sudden see all this anatomy and we realize, hey, the nerves are going this way, the nerves are going that way. We can spare those nerves. And so now the impotence rates fell through the floor. And not only that, but the cancer cure rates went up because it turns out if you control the arterial inflow and venous outflow to a structure before you start rooting around the cancer, at least this was my understanding of it, and I'm not a cancer surgeon, but you prevent any cells from escaping. So everything improved, and I think this all started. I tend to go on these tangents, but I think the idea when we teach this now is, once you see these nerves, you will never unsee them. And so many of the people that we teach go, oh my God, I watch you do these cases. I saw this video of this operation you did. And I'm like, I see these things all the time. I just thought those were like little nothings. We could just cut them and, not worry about them. But, turns out that, that 15, 20 minutes that you're going to spend is this person's forever that they're going to live with. So it's certainly worth the time. And again, I think to the point that's probably most relevant to your audience, I think if you understand where these nerves are, if you understand how they function and how they pass through all this tissue, and in the back of the head, for example, that these nerves take very circuitous routes. It's not like a straight line to the finish. You then very quickly realize how postural changes, airway changes, where you're holding your neck in certain ways, certain motions, maybe not the first time, but the 1,001st time you do that will eventually lead to problems. And I think the goal with this is that at some point we will be able to understand it to the point where we can actually prevent a lot of these things from happening.
And what I want to ask you about is whether or not you think I'm crazy for considering that maybe it's my tongue that is somehow having this chain reaction on headache culprit nerves in my neck. I'm even considering having a orthognathic double jaw advancement surgery as a way of releasing my tongue and allowing it to relax, so to speak. Obviously, that's a brutal procedure to go through. Not as bad as it used to be. Surgery times are down from 8 or 10 hours a decade or two ago to in some cases 1 hour if custom pre-printed titanium plates are used, or even if the surgeon is bending plates on site, it can be done in as little as 2 to 3 hours, which means less recovery. You don't end up looking like a beach ball on day 3 or 4 after. It's not as bad and brutal as it used to be, but we're still talking about hacking the jaws off and plating them forward. Right? It's also an extremely expensive surgery. Oftentimes it's approaching 6 figures. So it's a big leap for me to take that. And so I'm trying to do my due diligence and, steel manning the case against myself doing that surgery by just considering, hey, maybe I'm just one of these chronic pain patients that's losing his mind a little bit and is almost like a Munchausen syndrome type thing where it's like looking, reaching and grasping for anything I can do to try to treat this, right? So my working theory now is that it's my tongue being trapped inside of a mouth that's about 1 centimeter, maybe 7 millimeters, to recessed,
Mm-hmm.
retrognathic.
Mm-hmm.
And I've been running this experiment for the past 2 months where 18 hours a day, I'm flopping my tongue out of my mouth like this. And I
Mm-hmm.
can show you photos, candid photos that were taken of me just going about my day, playing with my baby. And I went on this camping trip and a bunch of photos where you can see my tongue is just out of my mouth.
Mm-hmm.
And my neck has never felt better. It's kind of bizarre. And I even have this device now that pulls my tongue out of my throat or out of my mouth at night when I sleep. It's just a cheap piece of silicone that
Mm-hmm.
suctions my tongue out of my mouth and braces it against my teeth and my lips.
Mm-hmm.
And my theory is that somehow this is allowing muscles around my lesser occipital nerve, maybe the aberrant branches of my lesser occipital nerve,
Mm-hmm.
to relax and not compress those nerves. Your understanding of the muscles that are around this area here behind the ears,
Mm-hmm.
going down the side of the neck, is there any connection, direct or indirect, to the tongue that you're aware of there? I mean, just what are your thoughts on that in general?
Okay, so
And
it's a
please,
lot
if
to
you think I'm
unpack
nuts,
there.
please tell me. Yeah, please.
No, not in the least. That was going to be my first comment here. Um, so the first thing is, I think while there are certainly patients out there who confabulate, which means make up symptoms, and they're like these Munchausen's things, people really truly even psychologically believe perhaps that they have something that you could physically demonstrate that they don't. I think the overwhelming majority of people have uh, real pain. It's just that we don't understand it quite well yet. And, that sort of example I gave of the groin hernia, those people, every time we saw them, we would be like, oh, you've got another hernia. Oh, we can't find another hernia. There must be a problem with the mesh. Oh, it's not the mesh. Like, that's what we knew. Now I see those patients, I go, I think you have a nerve problem. And, I see those patients still in the office all the time. And they're like, oh my God, you gave me the shot and it went away for 6 hours and we did the operation. And, it's been 6 years and it's gone. How come nobody else knows this? And I think it's because still people don't understand or appreciate the role of nerves for all of this. That being said, the question is what is causing, and in that example with the hernia, it's usually either the hernia that also pressed on a nerve. So you had a hernia to fix it, but it was pressing on a nerve, and that was probably causing some of the pain. So the mesh fixed the actual hernia, but you still have to fix the nerve. And I think your point is, or your case is a really good example because you're clearly a well adjusted, normal person, and yet you have all of this discomfort, right? And if that's the case, at least I would have to take it seriously. Now, it's one thing to be able to say, listen, I'm not sure what's wrong with you, but your idea is actually a very reasonable one. And I think, the tongue is the strongest muscle in the body, believe it or not. Stronger than any of the quads. It's stronger, certainly per capita, so to speak. So given the size of the tongue, it can really produce significant pressure. If it's not working correctly, all of the muscles of the face, the jaw, and even the neck have to adjust in order to open things up. And, so if the tongue is constantly flopping in the back of your mouth, there's lots of things in terms of CPAP machines that we use to blow air in there and try to open that airway. Your muscles will also hypertrophy, meaning get bigger in ways that perhaps they weren't intended to do, right? And so I think that, your very conservative ways of kind of experimenting with things that will decompress the jaw and the airway with your tongue highlight the fact that you're absolutely onto something. Okay. And I think it is not at all unreasonable to suggest that if you perhaps, let's say, and I'm not suggesting this, I don't do what are called bilateral sagittal split osteotomies, as you know, BSSOs, to kind of, break the jaw and advance it forward. And those we did them when I was, a trainee at Harvard, really huge orthognathic cases. But I think there are reasonable reasons to think that that makes a lot of sense, because the other thing that I recall, and it's been a few years, is that a lot of those kids that were born congenitally with retruded jaws and small airways also had headaches as part of their symptomatology.
Hmm.
And it's a hard thing to kind of recognize in kids because kids don't, tell you, oh, I've got this tension headache in my forehead here. It really hurts. They'll just say, oh, I don't feel good. My head hurts. And you don't know what that means. But yeah, a lot of those kids had headaches. So I think the way I look at it is the whole body is connected. And if, for example, I saw a lady today, she had had a couple of breast augs and came in and she has arthritis and there are other things going on, but she seems to think she has breast implant illness. And because of her breast implants, and one of the symptoms that
What is breast implant illness?
so it's a constellation of symptoms where people have all sorts of, I don't want to say non-specific because it is considered a real entity. It just doesn't have like here are the 5 criteria that you need to meet to have it. But she has a lot of headaches. People get sick very often. Whereas they could say like 5 years ago before I had these implants, I wouldn't get sick very often. They have unexplained aches and pains throughout their body that they didn't have. It's almost like there's some kind of inflammatory reaction that your body is having to the presence of an implant that then extends to all the other tissues, with the point being the whole body is connected, right? And so the other thing that was interesting is when she came in for an examination, she says, like, if I press here, boy, my nipple lights up. It's like an electric shock. And turns out she'd had a couple of operations, all someone else, to medialize the implant because it had fallen too far towards her armpit. So there's a lot of scar tissue from a lot of surgery there. And, wouldn't you know it, when you numb that nerve, that pain gets better. And she then would call and say, hey, I actually felt really good the rest of the day. Like all these other aches and pains kind of went away. And where I'm going with this is it possible that this nerve that is chronically irritated on the side of her chest wall is been irritated since 2011 when her last breast operation was? So it's been 13 years. It's not a short amount of time. And because that forest fire has never been put out, now the whole nervous system is on fire. And she has pain here and she has pain there. And and I'm not suggesting it's not breast implant illness. That could still be the case. But she's had all these workups for all these autoimmune disorders, lupus, and da-da-da, and everything's come up negative. But maybe her nervous system is just so sensitized because this one little nerve is like the little campfire that's now spread to the whole forest. So I think that your idea, frankly, is not only not crazy, it makes a lot of sense. So,
Do you think my anatomy could be so unique that I'm one of just a very small percentage of people that have this specific condition? Do headache disorders present like that regularly, where it's really kind of a totally unique case based on maybe aberrant divergent anatomy?
so I think it's probably not that you're so unique. Sorry if that's you are a unique
No.
individual, right? But I don't think it's actually that you're so unique. It's that you perhaps are just the only person who has recognized this connection. That's the thing. Like, at one point, how did all this headache surgery start? I love this story, and you know it. When you do brow lifts, you remove part of this musculature, right? And so this guy, Bauman Gairon, who was doing hundreds of these and had a very successful cosmetic surgery practice, had all these patients come back to his office. He was saying, look, I have all these people, not everybody, but let's say 20% that say, I love how I look. But just so you know, I had this surgery. I used to have these terrible headaches before. And now they're either gone or so much better, I don't even really pay attention to them anymore. How did this brow lift cosmetic thing make my headaches better? And it turns out he was, unbeknownst to him, decompressing nerves and removing injured ones in other areas. And to, again, his credit, and thankfully for that, because it's the reason we have this whole field of headache surgery, he studied it in a more formal way and realized, oh my God, for some of these people, they need to have surgery if they have this kind of headache symptom or that kind of headache symptom. And so you began to recognize when people come in and say, look, whenever I do this or get angry and stressed, I have this pain and it kind of shoots up here. You don't all of a sudden have a migraine. Or if, let's say, you had, scalp surgery the other day and you're 45 and you had to remove a cancer and you did a skin graft and now all of a sudden you have bad headaches, you don't all of a sudden have migraines. Whereas for the first 45 years of your life, you didn't. You had a nerve that is stuck in the area where you did the skin graft, and it's causing a problem. So I think that you're probably the canary in the coal mine, so to speak. You're lighting the way for other people to recognize, hey, wait a minute, maybe this is a thing. And there's a lot of people who have. So when people have like auricular temporal neuralgia, some of it is caused by temporomandibular joint disorders. And certainly those need to be addressed by orthognathic and oral surgeons. I'm not saying that doesn't exist. 100% it exists. And yeah, in some cases, it can cause a lot of severe pathology. But when you treat that appropriately with maybe something as simple as a night guard or some jaw exercises or even a little bit of Botox, and you still have zinging, shooting pain, it could be that the inflammation caused by whatever's going on has scarred up a nerve after that many years. And, in that case, I think, like I say to my headache patients too, and like I talk to all the neurologists I speak with, certainly while maybe 1 out of 3 patients are cured, so to speak, of their headaches and don't really have severe migraines, quote unquote, anymore. They're not migraines, it's neuralgia, nerve pain. After surgery, that means still, 2/3 of patients still have something. It's usually with the volume way turned down, much less frequent, much less severe, lasting much shorter periods of time. But they still have chemical abnormalities that likely perhaps induced this nerve entrapment or were just happening at the same time as this nerve entrapment. And so we still need neurologists to help manage the pain, but now the pain is not caused by a mechanical problem, it's the residual chemical issue. And lo and behold, the pain medicines are often more effective. So it's a win-win-win-win. The patient's better. I feel good because I've done an operation. The neurologist feels good because he or she can now prescribe the same drug and it really works. And so I think that in the jaw case, maybe you need to have whatever you need to have to manage the TMJ joint disorder. But maybe there's also a little nerve that's entrapped and you can fix that. And you fix both of those things, you do really well. Right. So, yeah.
How do you navigate the phenomenon where let's say you have let's assume that my theory is correct and I have this skeletal structural issue in my jaws that's resulting in this neuralgia.
Mm-hmm.
Yet the surgeon who I would rely on to correct this structural issue is trained to only operate for very specific reasons: occlusion, airway, in all the symptoms associated with sleep apnea, such as, fatigue and, all of the normal symptoms associated with sleep apnea. And they look at someone like me and they say, hey, look, I don't treat headaches. Okay.
Right.
How do you navigate this frontier of medicine where you have this misunderstood peripheral nerve pain world where you have all of these patients suffering from potentially structural issues, and the surgeons that they depend on to correct those structural issues don't really acknowledge the relationship between the structure and the nerve pain?
Yeah. So that's a really hard one. It's a really erudite and subtle question. And it reminds me of a saying one of my mentors at Harvard used to say is that, Ziv, you have to be able to see what you're looking at. And so a lot of times people don't see the problem that's actually there because they don't know to see it. Right. And so, a million years ago, if all of a sudden you had redness and pus coming out of a little cut in your finger, it's, bad humors. God said, that you did something bad. And now we know there's a bacteria or a fungus that got in there. Right. But in 1604, there was no, what do you mean? Some microscopic little animal, but you're talking crazy talk now. And yeah, back then those people were considered lunatics. And then, somebody invented the microscope and all of a sudden you're looking down, you go, oh my God, what is all this stuff?
Right.
So I think the best way to do it is, first of all, I think it's working within the system that is important and trying to do it in a productive way. So from the patient standpoint, I would make sure that you've been worked up for all the sort of typical things that you would examine patients for. So, how is your airway? How is the position of the jaw in relation to other structures? Again, and that gets to this old surgical adage. When you hear, at least in America, when you hear hoofbeats, you think of horses, not zebras. In other words, common things occur commonly. I suppose if you lived in Kenya, you would think zebras first and then horses, but the point is the same, right? Common things that you run into occur commonly. So you then make sure that you have imaging of your cervical spine, that you don't have uh, a pinched nerve root, you haven't fractured a vertebrae, you don't have a herniated disc or something. You could then, for example, have surgery and then like you've had done, and we've seen your anatomy, and we could we've done a good decompression. Yes, we removed a couple of these minor little branches, and you've done to a certain degree well just with that. But there's, like the point I was making earlier, with you need often a multidisciplinary approach to these things to really hit the home run and get across the finish line. You need a whole baseball team or a trainer as well as an athlete. The surgery will take you so far, and then you kind of approach hopefully a relatively open-minded physician and surgeon who will say, look, I spoke with this thoughtful young man. He is not crazy. He's not looking for drugs. He's not looking for time off work. There's no sort of other motivation here. Who wants to have surgery when they don't need to? Clearly not Ronald, right? And here are all the factors that we have gone through so far. And we've checked off all these boxes. And then he has all of these things that he's done. And every time we give him the suction device for his tongue, and when he is doing this, he feels better. Who wants to walk around life doing that? But if that's really what makes you feel better, there must be something to that fact. And look, at some point you will find someone who's willing to make an argument that, I think this makes a lot of sense. Here's how I would tie these two together. And then, you're presented with the risks and benefits as well as alternatives to treatment of, let's say, a jaw hack, and, as you put it earlier, an advancement on both sides. And then it's up to you to make that calculus, like, is the juice worth the squeeze? And if the answer is yes, hopefully you do that. I think as I always take this approach, I was really, until proven otherwise, and it's extremely rare that you're proven otherwise, although it has happened, I always trust my patients believe what they say. They're not crazy. They're good people. They don't want to be seeing me unless they have nobody wants to go to the doctor unless they want something or really need something. And then I think the reverse is true. When patients come in and they're not accusatory and they're not angry and they're not, mad at me or everybody else for that matter, but they're like, hey, look, this is how I'm thinking about this. Would you consider doing something like this? I actually take that very seriously. I'm not going to say I've always agreed and done what patients say, but as you heard me say during your surgery, like, we have several options when it comes to these nerves. You can cut them all. There are patients come in and say, I don't care how much numbness I get. I just cut everything. I don't care. There are other people that say, don't cut anything. Don't cut any nerves. I don't care what you find. And then there are other patients who say, look, doc, use your best judgment. If you feel like you have to do that, that's fine. And that's part of the conversation that we have. And I've had patients that, I thought, yeah, I probably should cut that nerve, but they didn't want me to cut it and have done really well post-operatively. And that's, for me, when I look at those pictures that I took in the OR, I'm like, okay, gosh, that nerve I thought really looked terrible and I was going to cut it, but the patient said absolutely not to. How come they're better? And then you start looking at their history and what is it about them that, makes them able to tolerate that versus, someone else. And, the answer may be X and may be Y, but that's how you learn and that's how you develop as a surgeon. And I think The hard part is that not, from speaking as a physician now, most physicians are, tunnel vision. They got their things. They got to get through, these 800 things today. They're going to do the things that they were trained to do and nothing else. And I think being open with a reasonable, obviously nobody wants to sell snake oil, but being reasonably open to novel ideas is how we develop as a profession. I think, and but that's why it's called the practice of medicine. I mean, I'm certainly not doing the same things I do now that I did when I first did my first headache operation 15 years ago. If I am, then I'm already, 8 years behind the eight ball. And in fact, when we give which I just ran this year as president of the Migraine Surgery Society, the advanced migraine surgery course, one of the things that I run through all the people giving the speeches for is say, if one thing, you got 30 seconds, what's one thing you either do or don't do now that you were doing or not doing 5 years ago? And, everybody has a pretty good answer for them. Oh, I use the Doppler a lot more to see patients. Oh, I do fat grafting now instead of cutting nerves as a first step. Or, I no longer resect as much muscle here because I really realize it's where the nerve is stuck at the rim, the roof of the orbit. And so I don't have to, worry about kind of giving people that weird kind of glabellar structure as a potential risk, that kind of stuff.
Mm-hmm.
So
well, I really appreciate your feedback on my own case and continuing after all of these years. It's what, 7 years now that you've been an advocate and a friend and a surgeon for me. So thank you for the continued advocacy on my behalf. I want to pivot now to ask you about how you're now integrating a new technique into your surgical treatment of headaches, which is fat grafting. Can you tell us what is fat grafting and how is it used to treat headaches under your care?
Yeah. So fat grafting is literally just as it sounds. It's taking fat, usually with liposuction, from one part of your body. The liposuction has to be done in a certain way. It can't be like the vacuum assisted or power assisted or laser assisted liposuction that you do when you want to throw that fat in the garbage because you're looking for a contour change. And putting it or grafting it to another part of the body, in this case where you still have an irritated nerve. And the idea behind this is really twofold. One, you're actually providing additional structural support around a nerve. So the analogy would be if somebody was jackhammering outside your house for 5 days and the noise was driving you insane because it was nonstop, and you put on a pair of noise canceling headphones, you might not make it go to zero, but you would really turn the volume down on that. And that alone would make it better. The other thing that we've learned over the years, because the science of fat, as silly as this may sound, and I'm not talking about weight loss, but the science of what fat cells do and what is surrounding them and what they have the capacity to do, so their physiology and biology has really absolutely exploded. And there are entire societies, one called IFATS, which I think stands for the International Federation of Adipose Therapeutic Sciences. And these are really hardcore basic science researchers at some very prestigious institutions that study fat and biology and what fat's capable of, with the upshot being that we now know fat is one of the richest sources of stem cells in the body. And what we've realized is that when you graft fat from one place to another, for example, if you have a concavity after a lumpectomy for breast cancer treatment, and you want to just increase the volume there, what we realized was happening to the skin, because most people who have a lumpectomy also get radiation. And so you have those radiation, those burned kind of reddish, chronically red skin changes. It's like leather and it's tough. When you correct that concavity and make it a convexity so it's better in line with the breast mound, what we found was that the skin changes seem to be a lot better. And so there's a lot of regenerative potential within that fat. We now are really learning that not only are fat cells and the structures around them a good source of stem cells, but we're learning exactly which chemicals, what's called the secretome. What is it that these fat cells, these stem cells are secreting that is having these wonderful effects? And so the second effect of the fat graft is that with the fat, you're bringing in some stem cells. And once those stem cells take and start working normally in that area, they release chemicals that, again, have been shown very scientifically to be anti-inflammatory, neuroprotective, so they prevent the nerves from getting injured further, and neuroregenerative, so they can actually help nerves grow. And so the way this has really been, this is my game changer. When they give me 30 seconds, I really have to, because I talk for 30 minutes, but, I say 30 seconds, 10 years ago, actually even closer than that, probably 6 years ago, if you'd come to me and said, we did a decompression of the greater occipital nerve and I'm only 60% better, but every time the doctor numbs it there, I'm like 99% better. I want you to cut it. Well, okay, yes, we can do that. And those people did well, but there was a huge numb area in the back of their head. Now I interpose fat grafting and say, listen, before I just give you a half of your scalp is numb in the back of your head, let's put some fat around that. It's something we can even do here in the office. It takes about an hour. It works really well. And a full 70% of the patients that would have progressed to nerve cutting now never get there because their pain improves so much that they go, maybe I still have a little something, but Tylenol, Motrin, it's totally manageable. I'm not. And they still have their sensation. So that for me has been a real game changer. And we've seen it used by other people for post-mastectomy pain syndrome, for people who have amputations and have stump pain because of presumable neuromas there. Fat has been used successfully for that. So it's a really promising area, and one that, I've dipped my toes into very, very slowly. But it seems to be very effective, and presenting my third paper on it at the national. It's a poster this year, but hopefully it'll be a paper and eventually like a keynote speech. As the science behind it is further flushed out. But it's one of the things that I'm really excited about, mostly because, again, you don't need another big operation on a lot of patients. You could do a small thing in the office. They walk out. They can even drive home in some cases. And we've done it under local alone because this is not a huge volume of fat that we need to put in. It's usually about 3 to 5 milliliters per area. And yeah, it's working really well. So we're very excited about it.
Yeah, congratulations on all of those publications. When I first met you and you proposed that you might have to cut some of my nerves if, when encountering them during the operation, they were just too beat up to be saved.
Mm-hmm.
My concern was, well, can you just cut nerves? That's kind of scary. And you told me, well, it's rare, but sometimes when you do cut a nerve, you can get a neuroma. Essentially, maybe you can explain accurately what that means, but essentially, you cut a nerve and it doesn't heal as well as you would like it to, and it can continue to cause pain. Is fat grafting something you're doing to address neuromas in patients that have had excisions?
Yeah, so it's actually not quite that. So what is a neuroma? Neuroma is a histologic definition, which means if you cut out a part of an injured nerve and you look at it under a microscope, it's going to have one of two characteristics. It's going to have scar, and it's going to have regenerating nerve fibers. Okay, that's a neuroma by definition. So clinically, a neuroma is just a very painful area where there's a nerve. Okay, whether it's been cut, stretched, even whiplash if you touch an area. Carpal tunnel is not a neuroma because the nerve hasn't been cut, but it's that kind of idea. Okay. Now, when you cut a nerve, you're absolutely correct. You have good memory. You can't just cut it and hope that everything goes well. So if you cut a nerve, you have to do something with it. We either bury it in the muscle. You can connect it to another nerve. You can put a muscle graft around it. It's called regenerative peripheral nerve interface. You can put a nerve cap on it. You can put a very long, like a ridiculously long nerve graft on it, with the presumption is the nerve will never regenerate through that whole graft. And so it will kind of die off at some point in the middle. And then you'll have this nerve end over here that is basically numb, is non-functional. But nerves want to do stuff. Okay. So the way that I use fat grafting is not so much because I think patients have neuromas, because if you have a true neuroma, you need to cut that injured part of the nerve out. I don't think fat or medicine is just going to make that structure go away. Okay. So the recalcitrant headaches that I see, those nerves, like when we've reopened them many times, when I used to go to cut them, those nerves didn't have big neuromas on them. They just still looked a little inflamed. And the question was, well, when I finished the first operation, they were inflamed. When I started the first operation, they were inflamed. And that was because there was so much compression on them for so many years. Maybe the inflammation just never fully died down. So the way the fat grafting really works, and I think this is why it's so intriguing to me, is we're not we're actually hopefully helping the nerve function better. So the fat graft, when it contains stem cells, and we now have a way to sort of concentrate that, the stem cells will actually release chemicals that will help the nerve heal. So those nerves and that nerve pain that we treat, like perhaps for you, and this is again just something to consider, if there's still a certain pain around here, if every time you numb it, that pain goes away, then that nerve is still irritated. Now, do you have a neuroma? Well, if you had a neuroma, you probably couldn't even touch it without like absolutely losing your mind. You couldn't like lie on it. But the other thing is maybe that remaining part of the nerve is just still not functioning very well. And when you add the fat, that neuroprotective and neuroregenerative element to the stem cells that you're bringing with the fat may be able to make that nerve actually function better. So you don't have to necessarily mechanically do it, but in that case, it's a sort of a surgical way of bringing in a certain array of substances released by the stem cells that will make that nerve function better.
Mm-hmm. Mm-hmm. And how are you using this? Are you integrating it into the first surgery you'll do with someone, or is it only something you'll do when a patient comes back?
Right. That's a great question. The answer is the latter. So most of the time, the decompression is enough. Okay. Now, there are certainly patients who say, I'm 60% better, and technically that's a success. Most of the surgical literature will say if you're at least 50% improved with regard to frequency, severity, or duration, that's a success. But they say, look, I'm 60% better. I don't want to be numb. Is there anything else you can do? 10 years ago, the answer was, sorry, no. Now the answer is yes. So, but that's, still, I would say, only 15 to 20% of all the patients. So we're not at this point integrating it as part of the initial operation, but it's not a crazy thought to say, maybe if you asked me 5 years ago, what's the one thing you're doing now that you weren't doing 5 years earlier? I would say, look, I'm adding a lot of fat around these nerves at the time of their first operation. And boy, nobody's coming back and saying they still have pain. Whereas before it was 10% of patients still, were not 50% better. And then another 5 to 7% were like 60% better, but said, I wish I was like 80, 90% better.
Mm-hmm.
So,
you have a unique background in terms of your surgical training, which is that you have training in plastic surgery and in cosmetic enhancement procedures. Is that correct? Please correct me if I'm wrong at any point.
Yeah.
My audience might be familiar with the fact that fat grafting is often used as a cosmetic enhancement in orthognathic double jaw surgeries. Specifically, there's an Italian surgeon named Mirko Raffaini who will do it to, add volume along the ramus. He might remove fat in certain places, add it in other places. So this idea of manipulating fat, adding it, removing it, is a kind of a cosmetic, or has a place in cosmetics too. Does your background in cosmetics, is that what kind of opened the door to you to experiment with fat grafting, or did that come strictly from your treatment of peripheral nerves for pain?
It was actually the latter, interestingly enough. I mean, I think that you read enough about, how to treat pain, and you do enough surgery, you're certainly going to have patients that aren't as successful as you would hope. And again, I don't give up on my patients unless they give up on me first. And I tend to be a little bit of a honey badger when it comes to trying to figure out, like, well, how come Ronald isn't doing as well? Like, I need to try and figure this out. It kind of bugs me. Like, the operation went great. I saw this, I saw that. The nerve was this, the nerve was that. With everything we know, he should be better, but he's not. So either you're nuts when you're not nuts, or there's some other thing that is going on. And again, in these cases, I think it's the intrinsic function of the nerve that's not going well. It's not something externally pressing on it, but now the nerve itself is not working well. And so, sure, the medication trials sometimes can help, and if that manages things with no side effects and it's not costing you $18,000 a week, that's a very reasonable way to manage it. But if that doesn't work, and so again, I started to read about this, and I've seen, uh, you know, uh, uh, I can't tell you how many patients where I've done decompressions, and I first noticed this very commonly in the lower extremity when we were decompressing all these nerves. The ones that were chronically compressed were surrounded by fat because your body wants to cushion these nerves. Nerves seem to love fat. The Schwann cell is a really fatty kind of lipid-based cell that not only helps insulate the nerve itself so that the nerve impulses get carried very quickly, so that some of these reflex things, you put your hand on a hot stove, you don't think, oh gosh, my hand really burns right now, that's pretty painful, I should move it away. You move your hand away before you can even say ow, right? That's because the nerve impulses go so quickly, and it's the Schwann cells that insulate the nerves that help them do that. And so it is when I saw all of these nerves completely surrounded by fat with chronic compression, I realized, your body's trying to do something here. Now, when the nerve is in a fixed space and you add fat in there, yes, it's soft and squishy, but you're actually adding volume to an already fixed space. Now there's more pressure. So if you open that up, you do the decompression and then add fat. Now it's a different scenario because the landscape was different. And that's where a lot of this came from. And, again, as you read about it, you see I'm not the only kind of kooky guy out there. And again, people have done this very successfully for post-mastectomy pain syndrome, for stump pain. People are talking about it for shingles, post-herpetic neuralgia, which is a nerve problem that is extremely painful and very hard to treat. Maybe you don't need, quote, big open nerve surgery. Maybe you can just kind of put a little bit of fat around the nerves that you think, because that virus which gets activated that causes all that pain within the nerve and the inflammation of the nerve, it's a specific nerve that's being activated. And so if you can deactivate that nerve and help that nerve heal, maybe you can treat that. That would be a game changer for so many of these people, because that's a really, really painful problem.
Do you ever use fat grafting as a primary treatment for headache patients instead of decompression?
Yeah, so at this point, it's a good question. The answer is no, for the analogous reason I mentioned in the lower extremity. If there's something physically compressing the nerve, then adding more volume, even if that volume is water or fat, as squishy as opposed to concrete, is going to potentially cause more pressure. So the decompression, at least at this point, is thought to still be an integral part and probably the first part of what has to happen. And then if the nerve is still not functioning, again, maybe it needs more padding and you can add fat. Maybe it needs to actually function better, at which point, again, you can add fat. And I don't doubt that probably in 10, 15 years, when we understand exactly the secretome of these adipocytes, the fat cells, meaning exactly what they secrete, we'll realize it's, vascular endothelialized growth factor or nerve growth factor or glial-derived nerve growth factor or interleukin-1 that's really the thing that these stem cells are releasing that makes the nerve function well. And we'll be able to take a vial of interleukin-1 off the shelf, and I'll just give you that shot and you'll be fine. We're not there now, but that's the kind of exciting thing that I'm hoping for.
And what's gone on in the surgical treatment of headache space in the last 2 years since we talked? Has it gotten more popular? Are there more patients that are showing up at your office looking for help, or did it never really take off?
Oh no, it's continues to grow. It continues to grow pretty quickly. It is a slow and steady thing, but the growth has been nice. There's certainly more people around the world doing that. I just operated and lectured in Ecuador on Tuesday. I'm flying to Brazil to lecture again. So there's a lot of interest in this, and for good reason, because the U.S. is not the only place in the world where you have hundreds of millions and thousands of patients who have chronic headaches that all the traditional things have not been able to help. And I think that, in terms of what else is new, we have people working with companies who have very strong imaging backgrounds. So, for example, most of the traditional MRI that you get is done with what's called a 1.5 Tesla magnet. Tesla is the units of strength of that magnet. Now, a lot of standard MRIs are 3 Tesla magnets, and it's even better resolution. Some places have 4.5 or even 7 Tesla magnets, although those are
Wow.
research wise. There's one gentleman that's working with Siemens as part of their research. It's nowhere near ready for prime time with a 15 Tesla magnet. And they've done some like imaging studies, which he hasn't shared yet because I think they're waiting to publish this, which is the right thing to do. But he's like, oh my God, I'm seeing things that I didn't think you could see with an MRI. And so I think imaging studies targeted specifically at nerves will help us identify, hey, like for example, the greater occipital nerve, there are 6 potential compression sites. There's no good way to image that nerve. So we have to look at all those 6 compression sites for each patient. They're not all involved in every patient, so we don't have to do everything at each of those 6 sites, but we have to look at all of them. If we
You're
have
talking on the operating table. You have to
on
look
the
at them
operating
because
room table, yeah,
you can't image it with an
you
MRI.
can. But if you had a really good image beforehand that says, the problem is between points 4 and 5, well, that's a much less invasive operation now than what I'm doing, and perhaps targeted even more precisely so that the recovery is quicker and everything's better. So imaging continues to go well, and I think we'll have other adjuvant ways of managing nerve pain if you have to cut a nerve, and managing nerve dysfunction like fat grafts. So it's a field that continues to grow in its popularity, and we also have more and more data coming out that it's economically the right thing to do, because while surgery on the front end may cost more than a year's worth of whatever medicine, if you're taking that year's worth of medicine for 15 years, already that's cost more than surgery.
Yeah.
And if surgery fixes your problem after, or really makes it a lot more manageable after 6 months, well, 15 years of medicine. I mean, there's a slide that one of my colleagues recently sent me because she actually looked at the numbers. The cost of surgery, treatment, hospital facility fees, blah, 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 something like $30,000, $35,000 a year. The cost over that same period of time for conservative treatments, which would mean imaging, because you go to the ER with this headache, you're sure you're having an aneurysm. They do an MRI, the radiologist reads the MRI, all that gets billed to whoever. You're on this medicine, that medicine, then there's the ER visit. You're doing that a couple times a year. You're taking all the usual medicines. You're missing this day of work. That cost was, I think, like 4 times the cost of the surgery. And the more of that data we have, hopefully at some point the insurance companies will actually listen and go, hey, this actually really makes sense to try and cover these operations because we're going to save a lot of money. And most importantly, the patients will do well. So,
Right. Well, that's good news. I'm glad to hear that insurance companies and medicine as an establishment are opening up to this. I know it was definitely considered unorthodox at the time that I got into it in 2017.
Mm-hmm.
I want to just ask you a little bit more about this point you made about imaging. Airway patients and patients with jaw structure issues never really get MRIs. They're always getting cone beam CTs, CAT scans.
Yeah.
I wonder if as MRI technology gets stronger, let's say, and you can really see what's going on with nerves in and around the head and neck with MRI, that it could be used as an adjunct sort of imaging set that you could do to understand better understand cases like mine where you have nerve pain as a primary complaint, but a suspicion of a skeletal structural issue. So to be clear, MRI is the imaging that's used to see nerves and to identify nerve compression and nerve dysfunction. Is that right?
Yeah, the MRI. So there's a certain type of MRI called an MRN. So it stands for medical resonance neurography. And basically it's an MRI where the knobs and the software is tweaked to really highlight the nerves. Now, that's not the only thing, because you need to have the right anatomy imaged the right way. You need to have the right software and all the knobs turned to the right place on the dial. But then you also have to have a a radiologist that is adept at reading those images and interpreting what they're seeing. But that being said, again, other colleagues at our advanced migraine surgery courses have now shown some very nice images where they say, hey, look, here's an image of a nerve, and you can clearly see the nerve is normal up until about here, and all of a sudden there's this like big bulge in it. Well, maybe there is nerve swelling or a neuroma, and that's where you got to go look. You don't have to look down at the spine. You don't have to look like at the top of the scalp. It's somewhere in the middle. For nerves right now, MRI is the ticket. And again, I think it's not just MRI, but it's the high resolution and the 4K, 8K, 15 Tesla magnets that hopefully in a few years will be available to everyone, that will really be able to show us all these things that like the microscope at first we couldn't see, and now we can. And then the key will be, well, what do we do with that information? And the good news is that surgery for nerves, especially nerve pain, when it's directed appropriately, seems to be pretty darn effective, and that's really great.
Mm-hmm. I can't help but think that imaging and improvement in imaging technology is going to be so essential to continued development in medicine in general. I think it's a hugely underrated thing by patients, but you can't treat what you can't see, right? As you said earlier, what that surgeon taught you earlier in your career. If you have a few more minutes, Doctor, I'd love to just pick your brain briefly and very superficially about cosmetics, because my audience is very interested in cosmetic enhancement. A lot of my audience members, yes, they're suffering from health-related issues because of their, abnormal jaw structure, their small jaws, but a lot of them are also suffering from not liking the way they look because their jaws are narrow and or recessed. You have a background in cosmetics. Maybe you could... I don't know if you're technically a plastic surgeon, but I know you have training in plastics. Maybe you could just clarify that. And then I want to ask you, as part of your training, were you ever taught that jaw structure itself, the bones of the jaws, was a part of cosmetics, and that jaw surgeries could be used for cosmetic enhancement? Or is that not at all part of plastic surgery training?
Yeah. So first of all, I am a plastic surgeon, board certified.
Okay. There you go.
Boston, Harvard, and we had a lot of aesthetic training as part of our experience. Some of us focus exclusively on that, and then of course, there's certain areas of the body that you tend to focus on. So there are people that just do facelifts and nose jobs and eyelid surgery and ear surgery, and there's other people that do breast and body. Some people do both. But I think that that's the other thing, and interestingly enough, the people leading the way in this are actually the South Koreans, because it's the third largest country for consuming aesthetic surgery procedures. And one of the most popular things, and this is a really interesting cultural shift, for example, in Western society, so to speak, the number one procedure for rhinoplasty is reductive. In other words, people have these humps and they want to make them narrower or get a little scoop kind of thing. In Asian countries, because you have what's called a platyrrhine nose, which tends to be flatter, that's what that word means, their rhinoplasty is augmentative. So they're actually trying to build up a nice, more, quote, Romanesque nose. And that's a very popular procedure in South Korea as opposed to here, which is almost non-existent. With respect to jaw surgery, I think there's a lot of interesting things that are being done. And a lot of them are the things that you mentioned with regard to that surgeon you were referencing earlier. So buccal fat pad removal to sort of enhance the sort of a dimple that you might get here without hollowing your face out and making it look cadaveric. Perhaps placing that fat in little areas along the jawline to produce a certain type of aesthetic there. A lot of times, like in many of these Asian countries, because the masseter muscle, these muscles that bulge when we chew around the angle of the mandible, are hypertrophic, you can use Botox to kind of shrink that muscle down over time and give you a more feminine kind of ovoid look. You can certainly fat graft around, these areas to provide a certain appearance and prominence to certain areas of the jaw. And all those things are, done well and tastefully and conservatively and in the appropriate person, can actually be very helpful and can really make a noticeable change in your appearance, which a lot of people find very gratifying.
Yeah. Have you found that, and this is just anecdotal, have you found that patients that have more prominent jaw structure, fuller jaws, they tend to age better as a result of the bone sort of allowing the skin to have something to drape over as they age? Is that something you've observed?
It's an interesting question. I would say just off the top of my head, I haven't really thought about it, but the answer is yes, because the bony architecture doesn't change as much. The soft tissues are what give us all the problems that we have at 70 that we didn't have when we were 50. I think the other thing that we're learning, and we learned this from facelift aesthetics, 40 years ago, or let's say 30 years ago, when you looked at the, God rest her soul, Joan Rivers, not to harsh on Joan Rivers, that classic like windswept look, everything was pulled so tight, nothing really moved. There wasn't a wrinkle within a mile of the face, but it just didn't quite look right, you know? And so what we've learned is it's not just the absence of wrinkles and the amount that you pull, but it's the vector of pull. So maybe what you need to do is kind of pull up and a little to the side so that things are where they're supposed to be, as opposed to just kind of like this, right? And then on top of that is volume in the right place. I have a cute 10-year-old daughter, and so you'll appreciate this as a dad now. She's got this little fold of skin under her eye, but you would never look at her and say she has an aged appearance at 10 years of age. But the point is that little plumpness is a sign of youth. And if you look at your pictures, or I look at my pictures when I was your age and I look at them now, I can see this hollowness that I have here is because all of this fat used to be up here. And when you do that and you just do it on one side, you can almost see like the corner of the mouth goes up just a little bit. That big hollow there doesn't quite look as bad. And if you could imagine that this wrinkle would go away, that could look just a lot more youthful, right? And so fat in the right places and volume in the right places with the skin draped appropriately on that skeletal foundation is critical. And to the point with the regenerative medicine and fat, what we're learning is that if you could use some of the regenerative capacity of the fat to make the skin actually look good. So on some of these really highfalutin plastic surgeons, not in the US because it's not like quote FDA approved yet, but when they cone down and take, high resolution images of the skin on that 60-year-old woman that they did a facelift on 5 years ago, well, it's still 60-year-old skin. And so it has all the age marks and the fine little wrinkles. When they're doing their regenerative procedures now and they do those same high resolution images, that skin looks like the skin of a 20-year-old. So it's not only that things are now in the right place, but, it doesn't look like you've been done. So.
Right. That would be an argument in favor of fat grafting to add volume as opposed to bone grafting. This is an ongoing sort of debate in my space, which is, okay, if you want to build out the ramus and make the jawline look more prominent, do you add bone to the bone or do you add fat there? Dr. Michael Gunson, who is I interviewed recently, is a very prominent jaw surgeon in Los Angeles, says he likes to use bone to treat bony problems rather than fat to treat bony problems. But I think you just made a point where fat could be better because of the regenerative properties of adding fat to an area. Do you have any response to that point about the pros and cons of adding a sort of a bony substance, in the cheeks or along the jawline as opposed to fat?
Yeah. I mean, I think it's an interesting point, and I generally actually agree with Dr. Gunson. I think you try to treat like with like. So if it's a bony problem, you can do that, but I don't think they're necessarily exclusive, right? In other words, I think like so many things, if you create a structural foundation onto which you can build the external foundation, that works even better. And so the point I was making with these facelift patients is that, and they now look so much better, like from a conversational distance, but if you got up close, it's still 60-year-old skin. Whereas with now the regenerative therapies, even that looks healthier, younger, more youthful. And so again, it's giving you that extra little bit of a positive result that you didn't know you needed. So I think it could be both.
Is there a lasting way to sculpt a face without actually cutting the jaws and moving them forward by just adding bone and fat to an area? Does that something that has to be maintained every 5 or 10 years, or
So
if you, yeah,
yeah, good
please.
question. I mean, I think there's two components to that. First of all, it's your own tissue that you're grafting. So let's say that now the bone is not going to change very much, but the fat will. So if you gain 50 pounds, that fat will get bigger. If you lose 50 pounds, that fat will atrophy away. In addition, the effects of gravity really have an effect on tissues, and so volume placed in a certain point of your face today perhaps will not look as great 50 years ago when the soft tissue is sagged around it. And so there's probably going to be some element of maintenance or modification that you'll need to do with a little bit of time. The classic example of that would be if I, put in a breast implant today and it looks amazing and, you're 20. By the time you're 50, maybe you've had a couple of kids, you've breastfed, things are going to sag over the implant, but the implant's not really going to go anywhere. So now you do a lift over the implant. Now, in that case, it's surgery and it's, a little bit of a big deal. But, I think the point is nothing is going to truly last forever, especially when you're using your own tissues, because these are still human living things that will change and adapt to some degree with time. But I think we keep getting better at understanding these. And I think our ability to modulate and modify these things becomes more efficient and less invasive with time, which is also good moving forward. So,
Yeah, thanks. We're at over an hour and a half. I just have one final question for
shoot.
you, which is a big a big thing that patients try to discern when choosing a surgeon is, does this surgeon have a good taste for what a beautiful face looks like, and can I
Mhm.
trust them to plan a surgery well for me?
Mhm.
There's two aspects to a good jaw surgery: a well planned surgery, then a well executed surgery. You
Yeah.
could say, execution is routine with enough practice, but what can't really necessarily be taught is someone who really understands what beauty is.
Right.
Um, and the big problem in jaw surgery tends to be over advancement, right?
Mhm.
Surgeons get um, too aggressive in wanting to treat airway, make it as big as possible to cure the sleep apnea. But what ends up happening is you get this sort of like it's called chimp face, right? Where
Mhm.
the jaws are just too pronathic and the skin gets stretched. You lose lip competence, and a lot of patients will actually want to have a surgery undone to get rid of that
Mhm.
because they just look too different. People don't
Mhm.
recognize them anymore.
Yeah.
Um, in plastic surgery training, is there any sort of meta teaching of what is beauty? Uh, this is an objective way of understanding what beauty is when we sculpt a nose or when we treat
Yeah.
cheekbones or whatnot, or is it just totally the Wild West?
So I would say it's somewhere in between. That's a really difficult question with a lot of parts to it. But I guess as a 30,000-foot view on it,
Sure.
first of all, beauty will change over time. What we consider beautiful today is probably not what, if you look at the 1920s, where, a lot of women were considered quote unquote zaftig, which means a little larger in terms of size than they are, like in the 80s. And now, we've kind of gone back and forth as to what is quote beautiful or not. So things will change based upon the day and age
Culture.
we live in. Culture is another one, absolutely. So I think the answer to your question, in my mind, really comes down to number one, uh, when you talk to the patient and they're asking for this or that, is what they're asking reasonable? And I'm not saying are they crazy or just, absolutely, you know, perfectionists that they're expecting everything. But as a patient, you often don't know what you don't know. And so the key for the doctor is to say, okay, well, you want this. And with available technology and surgical techniques, when we do that, this will happen. When we do a little bit less of that, this will happen, but then this will not happen. And I think that when you listen to what the patient wants and then can articulate for them and explain clearly, hey, look, here's the risks and benefits to doing X, which is what you've asked for. Here are the risks and benefits to not doing X. And in my mind, if I'm hearing you correctly, I think you want this and you want the other thing. So I would say why, because it will give you some of the things you want from X without all of the side effects that you might have if you just did X. And again, that's part of the discussion that you have with the patient, which I think is really the take-home message. And when you're both aligned in terms of what your goals are, not only from an orthognathic standpoint, but perhaps from a, like, it would be unacceptable for me to look like, this chimp face. Here's a photo. I don't want anything that looks like that. You can, if you're both aligned as to where you see things going, then I think, you have a good person that you can trust to do your operation.
Fantastic. Dr. Peled, thank you for your time and for all your insights as always.
Always a pleasure. Always, we could honestly talk for hours, and it was great to get a chance to speak with you again. Happy to do it in the future if you like.
Thanks so much.
All right, my friend. Take care.
Bye-bye.